have to go about it.
All right.
Great. Just want to welcome everyone. I see a few joining in attendees here. Apologize for being a few minutes late. We had a few technical difficulties, so but it looks like we straightened everything out. Dr. Perretz is with us, and he's just bringing up his presentation, and we should be starting in 1 or 2 minutes. While Dr. Perretz is pulling up his presentation, I can address a few housekeeping items just while people are still trickling in. I can see one of the main things we always get asked is this recorded? It certainly is. We're going to be recording it, and we'll be releasing it on the BART Foundation website, YouTube channels, email notifications, so you'll certainly be able to rewatch the presentation later. We do encourage any of the participants throughout. If you're not familiar with Zoom, you can use the Q&A function. On the bottom of your screen, there should be a menu that pops up that says Q&A. I'll curate them throughout, so feel free if something does pop up to you to submit the question throughout the presentation, but we'll hold the questions actually and trying to address them all towards the end.
Okay, so right now, Brian, the only problem I'm having is getting my slideshow up. I apologize for this. I really did not think I was going to have this trouble. We've done this a million times. So I've got, all right. Hello. So if I put my share screen up there, there it is. Now I'm trying to get my slideshow going.
Yep. Yeah, I see
New
PowerPoint,
slide.
and then on the, I think,
There it
bottom
is.
right corner there, there's the.
But I don't really.
I think if you just click, I think from beginning on the left there.
There we go. But then I want to get rid of the thing on the left. So I'm going to go here. There we go. All right.
Perfect.
Now I have to get back to us.
Well, glad that's up. I'll take a minute and I can do my introductions now as well.
Thank you. The only thing I'm troubled with now is that I don't have a full screen of us because I need that to be able to share my screen.
No, I mean, your screen is shared up and you just switched pages to the first slide already. Like you're moving through it already.
I didn't want to do that.
Yeah, now you're back to the beginning. So
I'm back to the beginning, but okay, so you can see that, and then you can see me in the corner.
Yep.
I usually get this thing when I'm a host. I usually get this at the bottom of the screen. So you have my screen share already.
I do.
I see.
Yep.
Okay, that's.
I think we're good.
All right, that's great.
Well, we apologize to everyone again. A couple of technical difficulties there, but welcome. This is the first of what will be a series of webinar sessions presented by the BART Foundation. These sessions will be exploring alternative therapies for brain injury survivors. Particularly topics will include hyperbaric oxygen therapy, craniosacral therapy, photobiomodulation, neurofeedback, and nutraceutical supplementation. The BART Foundation hopes these lively interactive webinars encourage attendees to raise questions, express concerns, and learn about cutting-edge approaches to treating TBI and ABI. We will be having a second webinar on January 19th, and you will receive emails and notifications, so keep an eye out for that. Today, I'd like to introduce Perretz. He began his practice as an acupuncturist in 1987. After 8 years of practice in Eastern medicine, he saw that many patients were falling through the cracks in our healthcare system. Inspired to serve people better as part of the medical establishment, he went and graduated from the University of New England College of Osteopathic Medicine in 1999, completed his PM&R residency, which is physical medicine and rehabilitation, at the University of Chicago in 2003. His private practice, called Advanced Pain Solutions, is in Reading, Connecticut, and he's dedicated to the treatment of musculoskeletal pain, featuring an eclectic mix of osteopathy, prolotherapy, acupuncture, and neurotherapy. He has served as a past president of the North American Academy of Neurotherapy and sits on the board of the BART Foundation. Today, we will be speaking about how increasing oxygen availability is responsible for healing in most alternative therapies. And I'm really excited to present Dr. Perretz.
Thank you very much, Brian. And thank you, Joel. This is something that's very close to my heart, and I'm sure that's true for you and for many of the people who are watching. You know, when you enter the field of medicine, in all cases, you're looking for some kind of fundamental truths to follow. And one of the fundamental truths is that we all need oxygen to survive. So I am an osteopath. I'm not sure if everyone is familiar with osteopathy. So I will assume that you're not. And if you are, then, you know, perhaps I'll say something that enlightens you further. But osteopathy is a philosophy of medicine. The founder of osteopathy is pictured here. That's Andrew Taylor Still. And he was a Civil War era surgeon. He grew up in Kansas, which at the time was a territory. It was filled largely with First Nations people. And he became very familiar, not just with their healing methods, but with the religious and philosophical underpinnings that became part of his philosophy. His father was kind of a fire and brimstone preacher, and he became very disillusioned with what he saw in the practice of medicine, because at the time they were giving people mercury and calomel and what eventually became opioids. And he found that all of these things were poisonous, and he wanted to get back to a fundamental understanding of what the body does. And his feeling was, well, if God created bodies that are healthy, and these bodies have self-healing mechanisms, then our job as physicians is not to suppress symptoms by giving drugs. It's to help the body do what the body can do in an otherwise unimpeded situation. So he said, the fundamental thing is to give the body oxygen. He said the artery rules supreme. So the joke among osteopaths is that DO, which Doctor Osteopathy, stands for deliver oxygen. So how is it that osteopathic treatment delivers oxygen? Well, first of all, there is a connective tissue matrix in the body. This has been discovered recently, apparently discovered in the sense that the scientific community now has decided that there is a brand new system, as if we don't have hundreds of thousands of years of human development without this organ system. But the organ system they're referring to is the connective tissue system, the fascia, the stuff that interpenetrates everything in the body. The fascia is so much a part of our system that if you were to remove everything else in the body but the fascia, we would be able to recognize you as an individual person that you are. We would know who you are. So the fascia is actually kind of a primitive nervous system. It kind of acts as a signaling network. You could think of it as the 5G of the body, if you want to look at it that way, because there are little relay stations everywhere within the system, so that as you change the pressure or the tension on any of those cobwebs, those spider webs of connection, that the entire system is changed as a result. So this is the foundation of understanding any massage work, chiropractic work, any kind of manual work, any kind of acupuncture, any kind of electrical stimulation, magnetic stimulation. And these are things that we'll be talking about in future lectures. But if you recognize that the connective tissue matrix is the way in which those signals get passed, that really helps to build a foundation for further understanding. So if we look at the brain here, what you see in color is the purplish and lavender colors. The lavender color is the brain. The purplish colors and the blue colors are the fluids surrounding the brain. And this is the way that the brain gets its oxygen, because you do have a blood-brain barrier. And the cerebrospinal fluids are responsible for carrying not just oxygen, but electrical charge. So there is a system here that breathes in and around the brain. And if you can see my hands, I'm kind of mimicking a respiratory process, so that this is almost what it feels like. Now I'm going a little bit fast for the system. I think a more typical rhythm is more like this. Something between 6 and 14 rounds per minute. And the job of an osteopathic operator when we're on the system is to kind of plug into that rhythm and allow it to flow, so that the strains in that connective tissue matrix are things that we pay attention to. And as you tug on that respiratory mechanism and you feel the strains, it's a little bit like playing a game where you pull all of that into balance, and now the system is able to breathe better. And the better we get oxygen to the brain and the rest of the body, the better it functions. So, this might seem like a kind of ridiculously simple question, but why is oxygen so important? Oxygen limits inflammation and cell death. It promotes the growth of new collagen and blood vessels. It decreases swelling, and it mobilizes stem cells. Everybody knows about stem cells now. It's not something that we knew about many years ago, but now we understand that oxygen is part of not just the generative process, but the regenerative process. It helps us to rebuild ourselves, and all cells are kind of on a reboot system, so that 6 months from now, most of the cells in your body have been turned over already. And the aging process is really sort of an oxidation process. It's a rusting process wherein the DNA no longer has the opportunity to reestablish a new copy of itself with the same level of, not facility, the same level of, my God, why can't I say this word properly? You can't make a good copy anymore. It's kind of like when you do multiple variations of an old recording. You can't get the same fidelity that you started with. So oxygen gets into the cell actually by a process of diffusion and pressure gradients. So what you're looking at here is a magnification of what happens at the level of the lung alveoli, wherein oxygen works its way into the alveolus through your breathing mechanism, and the pressure that is created there allows the oxygen to migrate through the layers of the outer layer of the alveolus into the blood plasma, where it is then picked up by the hemoglobin in the red blood cell and then distributed through the rest of the body. So it is a matter of pressure gradient that takes that into the red blood cells. Now, hemoglobin can only carry so much oxygen. So some of the critics of oxygenating or oxygen creating therapies would say, well, you can't get more than 97% hemoglobin saturation. So how could you possibly think that you could get any more oxygen into the tissues than you already have? This is something that we're going to explore. What happens inside the cell? Once the oxygen gets into the cell, you have something that happens across the membrane of the mitochondrion inside the cell that creates what we know as ATP. This is the foundation of all of our energy. So this electron transport chain is accomplished across that membrane, and we get energy out of it. So the oxygen itself is not producing energy. It is donating electrons to this system that allows for the energy to be generated inside the mitochondrion. That's how we function. Now, what happens when you damage the cells that are supposed to be functioning at such a high level? So I've shown here the cartoon of a brain injury impact. And you notice that there are two pictures there. The primary impact is against that wall, and you can see the force pushing the brain up against the frontal bone and injuring the frontal lobe of the brain. But that brain in there is a little bit like tofu inside a bowl of Jell-O. You have this hard casing of the skull and this very, very soft, vulnerable tissue inside. So when you get that kind of concussion, there is a sloshing up into the front, the way that it would happen if you kind of sloshed your legs through a bathtub. And then once it has hit that front, there's a sloshing that goes back, and they call that second impact on the back of the head the contra coup. The annual incidence of traumatic brain injury in the United States today is at least, I say at least, because it's very likely that most of these figures are underreported, at least 1.7 million. That's a lot of people. So you're looking at a pie chart here that includes all types of, central nervous system injuries. The green area, which is the second largest one, it is for strokes, but by far the greatest number of injuries comes as traumatic brain. Now, this happens to be a generation of a stroke shown here on the screen. But the same thing would be true for any brain injury. You're going to have an area that is severely damaged. So those areas in red would be areas that are essentially dead cells. But the area in green, immediately surrounding it, is called the penumbra. And the penumbra is a very, very interesting feature of a traumatic brain injury, because this is an area that is not dead. It is underserved with oxygen. So in the case of a stroke, you may have arteries that can no longer serve that area, and you may have arteries that are partially blocked off, kind of downstream in the watershed. So that downstream area is underserved, and we need to find ways to get more blood and oxygen into those regions. Now, part of the problem with all of this, as I've suggested before, has to do with membrane permeability, because if you don't have a good membrane in the cell or in the mitochondrion, you're not going to be able to generate energy. So if you look on the left, you can see this is a representation of what happens when the membrane, by the way, all right, so the membrane shown here, I'm sorry, I'm assuming some knowledge that I shouldn't. What you're seeing from the top of the screen to the bottom of the screen is across the membrane. And so the membrane runs from those gray globs on top to the gray globs in the middle, I mean, at the bottom. And in the middle, you're going to see these fatty acid chains. So the membrane is made up of a water-friendly part, that's the gray part, and then the fat-friendly part, which is in the middle. And of course, you know, anybody who's ever done cooking knows that water and oil don't mix. But here we have a membrane where water and oil are inextricably linked together. And this is what makes us so special, because it takes a lot to get something through that membrane. You either have to have something that is water friendly on one end and oil friendly on the other, like a DMSO product, for instance. Or you have to have some pressure gradient or some other protein to pull it through. There are gaps in cellular membranes that are designed specifically for this, but I'm just showing you the generalized structure to give you an idea. Now, what I am illustrating here, if you look at the left side of the picture, is that there are fatty acids there that are not shaped properly. They are not at all like what they show as the saturated hydrocarbon tails on the right side. This is what happens when we have a diet that is too heavily overloaded with trans fats, and many of those trans fats come from omega-6 oils. And there's nothing wrong with omega-6 oils in and of themselves, but when we tend to cook with omega-6 polyunsaturated oils, their temperature for burning and breaking down is relatively low. So we end up with a polycarbon that is essentially a plastic. So when we eat foods that are highly trans fat oriented, you end up depositing those fats in the cellular membrane, and that makes for a plastic membrane. So if you think about it, you know, you take some plastic and put it over your face, you're not going to be able to breathe too well. The same thing happens at the cellular level. These membranes don't breathe well. They don't get oxygen well. So we have to find strategies that will allow for more oxygen to pass through the membrane. And we have one available through the BART Foundation. I happen to have come across this picture of the Barlean's omega oils. And so Joel, I hope you won't mind that I'm giving them a plug.
No, go right ahead. They've been very gracious to offer families of brain injured individuals a very steep discount on their products. If somebody needs to know how to do that, you can go to our website. On the very cover, right side, it has a link for that.
Yes. So the wonderful thing about omega-3s, and you'll notice that particularly on this, underneath where it says total omega, you'll see it says omega 3, 6, and 9. So as I said before, there's nothing wrong with omega-6 oils in and of themselves. The problem it has to do with how they break down into trans fats when they are partially hydrogenated, which is the industrial process for making these things last longer on the shelf. Excuse me. So if you are able to get a good source of omega-3, 6, and 9, all of these things contribute to a cellular membrane that breathes better. All right. So now we're moving on to other strategies that we can use to increase oxygenation. And the feature of the evening is HBOT, that's hyperbaric oxygen treatment. And I'm just going to move this so I can read my own writing here. And this was not on purpose, but I noticed after I took this picture to put on my slideshow that the company that makes this particular hyperbaric oxygen chamber is named Perry.
Very nice.
So yeah, that's right. So hyperbaric oxygen is a therapy that improves the oxygenation. So the solubility of oxygenation in a fluid is increased as the pressure acting on the gas is increased. So if you remember the picture of the lung, as the lung fills up with air, there's pressure across that alveolar membrane. And if we were to increase that pressure further, we could actually increase the amount of oxygen that is pushed into the plasma. So when you do hyperbaric oxygen, that increases the oxygen over the level that we normally, the normal pressure, which is called 1 atmosphere. And they will increase the pressure depending upon the tolerance of the patient up to 2, maybe even 3 atmospheres to increase that pressure to get the blood into, to get the oxygen into the blood plasma. It also increases the amount of oxygen in the cerebrospinal fluid and in the lymphatic fluid, which increases the metabolism of all the cells that are working together. So all around, HBOT pressures with 100% oxygen, which is another uptick in efficiency, because normal breathing air is only 21% oxygen, about 76% nitrogen. If we increase that oxygen to 100% and then push it in through pressure, you get blood plasma saturations that are 10 to 15 times normal. That makes a huge difference for the areas that I suggested were vulnerable, like the penumbra of the injury, right? So, is there any scientific evidence to show that HBOT has value? That's a good question. As it stands, there is a lot. And I will tell you, this is not new. I remember, all right, so I've been around for a while. I remember reading about hyperbaric oxygen when I was a medical student. This was in the mid-1990s. And even those studies were not new. So when I went into my rehabilitation residency, where we treated brain injury as a daily activity, I asked my attending physicians why we were not using hyperbaric oxygen to treat our brain injury patients. And they said something that absolutely blew my mind. They said, "We can't get paid for it." And I said, well, that's not a very good reason. I mean, I worked in a hospital where we had a hyperbaric unit that was sitting just outside the ER, and it went unused almost, I would say 98% of the time. There was never anyone using that. And as it's turned out, hyperbaric oxygen is approved for the use of wound healing, and it is approved for burns because somehow they've decided that if you have an injury on the outside of your body, well, that's okay to use oxygen. But if it's inside your body, oh, that won't work. All of that is to say that there's been a lot of research done on hyperbaric oxygen. And what I put together here, just to make it easy to consume, is that if they put together the data from all of those studies, that is looking at a meta-analysis, the average improvement for a brain injured patient, and almost all the time they did these studies with severely brain injured patients, led to an improvement of 3.13 in Glasgow Coma scale scores over the course of treatment compared with a control group. Now, I know you may be asking, what does that mean? The Glasgow Coma scale is a way of rating how severe the brain injury is. Some of you may be very familiar with this. You get scores depending upon how alert and oriented you are. So someone who is very severely in coma would not be opening their eyes to sound, or even if you touched them, they would not be responding if you called their name. And depending upon where and how severe the injury is, they might have spasms in the musculature that are either what they call decorticate, which is like this, or decerebrate, which is like that in extension. So if we put this all together, a mild brain injury is described as something that would be scored as a 13 to 15 on this scale. So if you add up the numbers, so 15 would be spontaneous eye opening, oriented to, place and time and person, and able to obey commands. So if you say, hey, could you get out of bed and put your shirt on? They would be able to do that. So if you put those scores together, you have a score of 15. That's as high as you can get. So let's just consider somebody, let's say, who is moderately brain injured, and that is between 9 and 13. So let's put something together like that. So this is somebody, let's say, who is otherwise kind of disoriented. They're not going to be spontaneously alert, but if you were to clap your hands, they might open their eyes. That would give them a 3. And then you would ask them, hey, do you know where you are? And they might say, yeah. It's like, oh, where are you? Oh, I'm at the movies. And of course, they're in the hospital. They might have been watching a movie, or maybe the TV was on or something like that, but it's just not coming out in a coherent fashion. So you put that together, that would be 4. And let's say they have abnormal flexion. So that's 7, that's 10, that's a moderate brain injury. Well, if you're able to get from 10 to 13, in other words, make them spontaneously opening the eyes and oriented, and then they have normal flexion, well, that's a huge difference in function. And if that is the difference that HBOT makes over the control group, that's a huge, huge difference, because each one of these numbers represents a major improvement in that patient's recovery. Now, when you put someone in a tube that has high pressures, it is not impossible to injure them. I thought it would be only fair to at least mention that there are some things that can go wrong, So let's say you've got somebody who has glaucoma. You put them in a hyperbaric oxygen chamber, that can increase the pressure in their eyes and cause them damage. If you've got someone who has emphysema, or some kind of problem with pressure in the lungs, you can cause a problem that way. If you have extremely blocked sinuses, that can make things worse. So this is not something that is applicable to everyone at all times. If you have an acutely injured patient, let's say there's a lot of bruising on the face and congestion in the sinuses, you can't just stick that person into an HBOT chamber and expect that they're going to come out comfortably. But these, if you just take these as a whole, they're very, very minor. And if you do a decent screening job before you take patients into a hyperbaric chamber, you're definitely going to be on the side of safety. There is also at the bottom of the screen the idea that you can develop oxygen toxicity, which sounds like a weird thing. Like if we're trying to increase oxygen, how is it that you can create oxygen toxicity? There are respiratory centers in the brain that respond to the amount of oxygen that they're receiving. And this tells you whether or not you should be breathing. So if you have high oxygen concentrations, the brain can kind of irrationally read that you're getting too much, and it can shut down the response from the brain to the lungs to breathe in. So that is something to keep in mind as well. But again, this is something that is understood well by those people who are administering, and they're able to account for problems like that. So what would it take to get through a course of treatment, and what do we expect? If I told you, if you lived in a polluted environment, and I suggested to you, well, I could get you some fresh air. All you have to do is spend 1 hour a day in fresh air, and you're going to feel better. Well, you go outside and you breathe that fresh air and you'll feel pretty good. But then you go back into your polluted environment and everything changes. So an hour a day is not going to be enough to turn your condition around. And the same thing would be true here. If we allow the body the opportunity to get exposure to all of that oxygen for just 1 hour a week, we can't expect that all of the healing is going to take place immediately. So it may take many dives, they call them dives, to achieve the desired results. And that should make sense. Is HBOT covered by insurance? Well, I already suggested that there are things that are covered, like burns and wound healing. But to this day, to my knowledge, hyperbaric oxygen is not a covered service by insurances. But the BART Foundation has found ways to partner with certain clinics to offer special exemptions for people such as veterans who have sustained brain injuries in combat, or others, for which the details are out of my head. But I'm sure that Joel would be able to chime in to tell us the details on that.
Perry,
Yeah.
the organization, it's a nationwide organization with 135 clinics, is called treatnow.org. Treatnow, one word, .org.
Mm-hmm.
And information about them is available on our site, but of course you can go to theirs, which is replete with information, one of the greatest sources about HBOT anywhere. And they have arranged with independent clinics throughout the country to offer veterans not only for in-service injuries, but for later injuries, any kind of ABI, including strokes. And they will make the HBOT available for free. And we've been honored to partner with them in a small way and make those couple extra clinics join them in upstate New York, where we're headquartered. So the Stram Center in Delmar, New York is among those. But you can go to their site and there's a search menu, and it'll tell you which ones are available in your state.
That's great.
Now, if you're not a vet, those same clinics tend to be extremely reasonable in pricing for other ABI and TBI survivors.
I'll just add another thought to this, because although I do not recommend this as an initial action, I actually know some people who have decided to buy their own hyperbaric chambers to use at home. And once they become familiar with the safety features associated, they can treat themselves. And if they actually come to the end of their need, they can actually resell those things, and the costs can be defrayed as a result.
If I can just add that those chambers are often referred to as soft chambers.
Mm-hmm.
They're not hard chambers like the one that Perry used in his illustration that said Perry. So that their pressures, maximum pressure is lower than a medical grade chamber.
I think it's like 1.7 atmospheres or 1.8 something. Yeah.
Often they max out at about 1.3 atmospheres. However, and I don't want to get too deep into this, it seems that if you do enough dives at 1.3, you get much of the same benefit that you would at, say, 1.5 or 1.6 or 2. So, and especially in parts of the country like Nebraska, where we've spoken to your Brain Injury Alliance, there are no treatnow.org clinics in Nebraska. So that might be a good option for you. Do it yourself.
Okay, thank you. Oh, what's happening now? That was it for me. I appreciate the opportunity to chat with everybody, and if there are questions, I'm certainly happy to answer anything that's come up. You see anything?
Thank you, Dr. Perretz.
Ryan?
There. Yep. Thank you, Dr. Perretz. It was very, very approachable and very informative. I'll take, we've had a few questions get submitted. I think the first two from Bob and Michael were referencing the same. The question references an individual that had a TBI in 2006, and they subsequently gone through 270 plus sessions of HBOT, seen progression, but their question becomes, could they expect to see even more progression resuming HBOT even after such a long period of time?
I don't have an answer for that, because I don't deliver that therapy in my office, and I don't have a lot of experience. My guess, based on what Joel was just saying and what I was just saying, is that the more the merrier. But I don't know whether after 270 dives we can expect a symptomatic change. There's so much that goes on with the regulation of the system that has to do with maintenance. You know, as I said, the aging process has to do with our loss of ability to replicate ourselves. And it could very well be that maintenance, because HBOT is used as an anti-aging therapy as well. Maintenance is a huge piece of this. So the answer is, I don't know, but I don't believe that it would hurt. Good night.
Yeah, if I could just add, I don't know either, but several former NFL players who use HBOT, the most famous, I guess, is Joe Namath, and we're Jet fans here, so long suffering, but also a fellow named George Vizga. You can look him up. He's been very involved in this effort for former NFL players. They're using the therapy 30, 40, even 50 years post-injury, and they are reporting improvements in their quality of life, which are supported by objective data, such as SPECT scans showing improved blood perfusion in the injured part, in the penumbra of their brain.
Right.
So as Perry said, it couldn't hurt, And it may, even if it's prophylactically preventing further degenerative conditions, which often come in the train of traumatic brain injuries.
I would not be surprised, Joel, if the NFL players are instrumental in getting these therapies approved,
I hope
because
so.
you know, it's high profile stuff. They are generating data, and you know, it's likely to be irrefutable, because you know, it's going to cost the NFL many, probably billions of dollars to start giving care to these people who are getting the CTE. You know, the I can't even remember what it stands for right now, but it's the
Repetitive
concussion
concussion.
related, concussion related injuries. And they are likely to be sued for that. So in order to get around the suits, I think that they would much rather collude with the insurance companies and get them to cover the therapy.
One can hope.
No, thank you both for your perspective. Another question I'd submitted was, can HBOT help with contractures as well? This individual's left arm is contracted due to a right side DAI.
Right. So this is exactly what I was referring to. And the answer is, again, I don't know, because when you're in that decorticate posture, that means that you have severely injured that pathway that goes from that part of the brain to the muscles. If that part of the brain is, let's say, part of the penumbra and can be restored, then yes, the chances are reasonable that the spasm can be addressed. You know, of course, we deal with those spasms in other ways by using Botox and things like that. But of course, if you can restore the original pathway from the brain, and then, this is critical, do the rehabilitation, because just restoring the circuit is not good enough, because by that time the circuit, you know, it has to be turned on. You know, just because you've got the light hooked up doesn't mean the switch is on. So you're going to have to do a rehabilitative process in conjunction with the HBOT in order to get the result. That would be my guess.
And a last question we had submitted was, is there any experience you can speak on using peptide therapy for TBIs?
Again, the answer from my experience is no. There's a lot of stuff going on in the peptide world right now. Most of these things are not approved. So if the doctors are at all conservative, they don't necessarily go out on a limb. They may be talking about BPC 157, which has to do with growth factors. And many people are ordering stuff like this on their own to use at home. But I don't have any direct experience with that. It is a growth factor that makes a difference, as far as I can tell. And there are others that are out there. There are exosome therapies, stem cell therapies, and all of these are potentially viable. But we will be, you know, dragged kicking and screaming in the United States with many of these therapies, because we are not willing to experiment nearly so much as some other countries. So there are people who are doing medical tourism as such to get their stem cells in Panama or South Korea or Thailand or someplace like that. And, you know, we may get there eventually, but we're slow going.
I'd like to just add that, not to this last question, but HBOT in general, that in some countries, most notably Israel, where much of the primary research about its effectiveness for TBI and stroke and other anoxic brain injuries has been done and is still being done. In Israel, HBOT is not an alternative therapy per se. That is, it is very much part of mainstream medicine. If one suffers one of those conditions in Israel, in all likelihood, one will be diving in a matter of days. And I guess they've solved that problem that Dr. Perretz experienced when he was an intern, namely, they found a way to get paid for it. So, and I understand their largest hyperbaric chamber in Israel seats, not like the one that Dr. Perretz showed, it seats up to 100 people at a time. It looks like an airport lounge, and they're going about their business, and they're imbibing the oxygen. So we, you know, we're certainly we've got a ways to go in this country. And,
well, I thank you both for your perspective and responses on this as well. Those are all the questions we had submitted. Do want to be conscious of everyone's time. I know we did run a few minutes late, but we also definitely are past the length of time of the webinar that we originally. As a reminder, this is recorded, so we will notify everyone as the recording goes live. It will be up on YouTube and the BART Foundation website. And you definitely will receive subsequent emails about future webinar series. We want to thank Dr. Perretz and Joel for this webinar and the good work they do at the BART Foundation. And we appreciate everyone's time that has joined us here tonight.
Thank you, Brian.
thank you, Brian.